So good evening guys. I hope all of you are doing fine. I am Dr. Omkar Sangita Del Prasonone, and today, as all of you know, we'll be starting with our part 2 of orthopedics test and discussion. As we all know, in the session of Sparks, the sessions we were discussing right now were orthopedics test and discussion series, on which the part 1 has already been discussed. Now it's the time for part 2, where we'll be discussing 20 questions out of the 40 that we were left with, okay, in a retrograde fashion as always. And I hope all of you are interactive, and I hope all of you would be answering in the chat box itself, okay? So don't hesitate to answer whether it is correct or whether it is wrong. Don't just hesitate, just answer, okay? So let's begin with our discussion without any further delay. I hope all of you have all of you have got, I feel, this PDF in various groups. Maybe it is the Afmg Telegram group, or it is your Afmg WhatsApp group, okay? So you can just get this PDF over there for your questions. And now let's start our discussion with question number 21, and the question states, the below given image, okay, the below given image is classified into which type of Salter and Harris classification of epiphyseal injuries? So as we all know, a long bone usually has 3 parts, okay? This end is known as, the ends of the long bone are known as your epiphysis, okay? The shaft is known as your diaphysis, and lastly the middle part, the neck, we can say, of the long bone is known as your metaphysis. And between this metaphysis and epiphysis there is one growth plate, and this growth plate is what? It is known as your physis, right? It is also known as your physeal plate. So depending on this, actually the epiphyseal injuries have been classified according to Salter and Harris classification. So what is the Salter and Harris classification? Let's see that first, okay? Please just answer in the chat box, okay? So this is what is your Salter and Harris classification of epiphyseal injuries, guys, okay? So please remember, according to Salter and Harris, the epiphyseal injuries have been classified into 5 classes, okay, or 5 types, okay? And you can just remember it by the Salter mnemonic itself. So how we can go? So type 1, okay, type 1, or we can remember it as separated growth plate, okay? Type 1 is what? It is your separated growth plate. So please remember, in type 1 epiphyseal injury, we can see separation occurring at the level of physis, okay? Metaphysis or epiphysis separate ho rahe hai, but the separation is occurring at the level of physis, okay? So please remember, epiphysis separates from the metaphysis at the level of physis. This is seen in type 1 Salter and Harris injury, okay? So please remember this. And which is the most common site? We'll be discussing the most common site also, where we can see these type 1, type 2 injuries, okay? So most common site of type 1 injury would be the neck of radius. So please remember, the most common site would be your neck of radius, okay? So please remember this. So type 2 is what? Type 2 can be remembered by A, that is above the growth plate. The separation is occurring above the growth plate. So please remember over here, okay? So where we can see the separation occurring? So please remember, the separation is occurring between the physis and the metaphysis, right? Separation kahan ho raha hai? Between the physis and the metaphysis, right? Over here, along with this separation, we can see what? We can see a fracture in the metaphysis. So please remember, in type 2 physeal injury, what we can see? There would be physis plus metaphysis separation along with a metaphyseal fracture. Along with the metaphyseal fracture, there would be a chip of metaphysis which is getting separated, okay? And this chip of metaphysis which is getting separated, this leads to a characteristic sign known as Thurston-Holland sign. This leads to a sign known as a Thurston-Holland sign, or a shiny corner sign, okay? So please remember this, shiny corner or a Thurston-Holland sign, due to this chip of metaphysis which is seen over here, okay? And which is the most common site of type 2 epiphyseal injury? So please remember, it is your phalanx. So type 2 physeal injury ki most common site is your phalanx, followed by your distal end of radius, So please remember this. Then type 3, okay, type 3 classification के according क्या होता है? It is below the growth plate, okay? Type 3 is below the growth plate, that is the separation is occurring below the growth plate in the epiphysis, okay? So here what we can see, here the separation of physis and epiphysis is occurring along with the fracture in the epiphysis. टाइप 2 में क्या हो रहा था, फ्रैक्चर कहाँ था, मेटाफाइसिस में. टाइप 3 में फ्रैक्चर कहाँ पे है, epiphysis में. Okay, so please remember physial plus epiphyseal separation along with the epiphyseal fracture, along with the epiphyseal fracture can be seen in type 3. Which is the most common site of type 3 injury? It is your medial mal. Okay, so medial malleolus is the most common site for your type 3 physeal injury. Next is your type 4. टाइप 4 में क्या होता है, इट इज टी, दैट इज थ्रू द ग्रोथ प्लेट. ओके, सो द सेपरेशन ओवर हियर जो होता है, इट इज थ्रू द ग्रोथ प्लेट. ओके, सो प्लीज रिमेंबर हियर द फाइसिस आल्सो इन्वॉल्वड, द मेटाफाइसिस इज आल्सो इन्वॉल्वड, वेयर एज द एपीफाइसिस इज आल्सो इन्वॉल्वड. ओके, सो यहाँ पे फाइजियल, मेटाफाइजियल एज वेल एज एपीफाइजियल फ्रैक्चर है along with separation of all these three. Okay, so please remember all three separate भी हो रहे हैं और तीनों में फ्रैक्चर भी दिख रहा है यहाँ पे. ओके, सो द सेपरेशन इज अकरिंग थ्रू द ग्रोथ प्लेट एंड विच इज द मोस्ट कॉमन साइट वेयर वी कैन सी टाइप 4 epiphyseal injury. It is your lateral condyle of humerus. Okay, so the lateral humeral condyle, here we can see type 4 epiphyseal injury. Okay, separation of all three fragments. Along with that, next one is your type 5 epiphyseal injury. Type 5 is remembered by ER, that is erasure of the growth plate. So what we can see over here, what are these arrows showing us? So please remember, these arrows are showing us the axial compression. Okay, ऐसा compress होता है physis. Okay, so this physis or your growth plate which can be seen over here, it is compressed axially. Okay, it is compressed axially and which can lead to physeal crushing. This leads to what? This leads to physeal crushing, also known as erasure of your growth plate. Okay, and the most common site for type 5 epiphyseal injury is what? It is your lower tibial physis. Okay, lower tibial growth plate or lower tibial physis is the most common site for your type 5 epiphyseal injury. Right, it is because of weight bearing, बहुत ज़्यादा weight पड़ता है right वहाँ पे, इसीलिए due to that reason lower tibial physis is the most common site for type 5 epiphyseal injury. So now let's go back to our question. What you can see over here, image में क्या दिख रहा है हमें? Okay, so just tell me what you can see in the image. What is your answer over here, guys? Now I'll just clear this image somewhat. So tell me what is the answer in this question number 21. You can see separation occurring at the level of physis and the metaphysis. यहाँ पे क्या दिख रहा है, separation कहाँ दिख रहा है, separation is at the level of physis and the metaphysis, right? So यहाँ पे separation है कहीं पे, right? एक बात. And along with that, what you can see, the epiphysis is taking along a chip of metaphysis along with it. Okay, epiphysis is also taking a chip of metaphysis along with it. That means there is a metaphyseal fracture. So this is classified into type 2 epiphyseal injury. So please remember, according to Salter and Harris classification, this is a type 2 epiphyseal injury, which is also the most common type of epiphyseal injury. Most common type of epiphyseal injury is type 2. Moving further to question number 22. A 25-year-old soldier complains of pain in the right foot. The X-ray is given below, which shows metatarsal fracture. The investigation of choice in this condition is, so they are actually asking you about the IOC, investigation of choice. Okay, the X-ray is showing what? The X-ray is showing a metatarsal fracture. Okay, here we can see the metatarsal fracture of the second metatarsal shaft. किसका fracture दिख रहा है? Second metatarsal shaft का fracture यहाँ पे, right? So what is the investigation of choice? Any answers for this? So just tell me, what is the investigation of choice for this kind of a fracture? Is it CT, is it MRI, is it bone scan, or we need to repeat an X-ray? So now we'll be discussing about these type of fractures. And what are these type of fractures called as? These types of fractures are called as your stress fractures. These types of fractures are called as your stress fractures. So what are actually stress fractures? Here the bone is totally normal. Okay, we have a normal bone. Okay, absolutely normal bone होता है. Okay, usually most common cause of fractures क्या होता है? It is your pathological fractures. Either it can be some infective etiology or it can be your osteoporosis, metabolic bone diseases. Okay, that is the most common cause of fractures, pathological fractures. But in this case, there is no pathology associated with the bone. Okay, there is a completely normal bone, but this normal bone is undergoing repetitive trauma. Normal bone is undergoing repetitive trauma. बार stress आ रहा है इस bone पे. Okay, so there is repetitive trauma, there is increased load on this bone. That is leading to the stress fractures. Okay, so important one. Which is the most common site of these stress fractures? The most common site of these stress fractures is what? Please remember it is your distal tibia. Again the same reason, there is excessive weight bearing on the tibia. So please remember, weight bearing is not a function, or walking is not a function of your fibula. Fibula का कोई काम नहीं होता है, इसीलिए fibula is preferred as a bone for your bone grafting also. ठीक है, fibula को काट भी दोगे, there won't be any issues. Okay, the patient would not face any issues. So the main function is of distal tibia. Okay, so the distal tibia, as it bears the weight due to the repetitive stress, the most common site of stress fractures is also distal tibia. Okay, what is a march fracture then? So please remember, march fracture is what? March means क्या? Drill. Okay, usually army क्या करती है? Usually soldiers, they have every day they need to go for your march, or they need to go for your drill. Okay, so due to repetitive marching क्या हो जाता है? There is excessive stress on your metatarsal bone, right? Metatarsal पे ज़्यादा pressure पड़ता है, and these metatarsals can undergo fracture. So please remember, march fracture is usually a fracture of the shaft of metatarsals. Okay, shaft of metatarsal. Which metatarsals? Usually it is your second and third metatarsal. Okay, if they ask one, so please remember your answer should be second metatarsal. Okay, so please remember, due to repetitive trauma, there is a fracture of the shaft of the metatarsals, more commonly the second metatarsal as compared to the third, and it is known as your march fracture. It is most commonly seen in whom? It is most commonly seen in your soldiers. Okay, soldiers, due to repetitive trauma. Also we can see this same thing in your marathon runners. Okay, marathon runners, and lastly in your dancers too. So please remember, soldiers, marathon runners or dancers are the profession in which march fracture is really very common, which is the fracture of shaft of metatarsal, more common of second than the third one. And what is the investigation of choice for your march fracture? So please remember, usually investigation of choice for your march fracture is nothing but your MRI, magnetic resonance imaging. So please remember over here, this answers our question now. So over here we can see fracture of your second metatarsal shaft. Okay, and this says usually a soldier, that means it is a march fracture, right? And the investigation of choice for a march fracture or any of the stress fracture is what? Option B, MRI. Next, moving on to our question number 23. Here a patient was diagnosed as a case of avascular necrosis from a bone scan, which revealed a cold spot. Okay, usually what happens, if a person has avascular necrosis in any of the bone, we prefer a bone scan, which is the investigation of choice. In bone scan we can see a cold spot. Cold spot क्यों दिखता है? Because the blood supply is cut off to that area, metabolic activity कम है उस area में, right? And that is the reason why we can see a cold spot on a bone scan after a scaphoid fracture. So ये avascular necrosis किसके बाद हुआ है? After a scaphoid fracture, which is the most common fracture associated with avian. Okay, which is the most common fracture. So usually these types of question are coming now. ठीक है, जो पहले ये सब चीज़ बताइए ना, ये सब बकवास है. ठीक है, उनका एक्चुअल क्वेश्चन क्या है? So which is the most common fracture associated with avascular necrosis. ये फालतू में उन्होंने description दिया है just to confuse you guys, right? So now just tell me what is the answer. Which is the most common fracture associated with avascular necrosis? Options are aviator's fracture, fracture waist of scaphoid, fracture neck of femur, fracture proximal humerus. What is your answer over here? Just be interactive in the chat box, guys. Just type your answers. That makes the discussion more fruitful for you guys. Okay, उससे ज़्यादा फायदा तुम्हें होगा. Whether it is correct, whether it is wrong, no one is over here to judge you. So now let's discuss few points about your avascular necrosis. Okay, so what is your avascular necrosis? As we all know, what happens after a fracture? Okay, अगर कोई fracture हो जाता है किसी bone में, what happens after a fracture? The blood supply is cut off to some particular area. Okay, so the blood supply is cut off to some particular area, and as this blood supply is cut off, there can lead to ischemia, and prolonged ischemia can lead to avascular necrosis of that particular area. This is your avian, right? So now avascular necrosis is common with which fractures that you need to remember. Okay, so avascular necrosis. So please remember, the most common site of avian is what? Please remember, the most common site of your avascular necrosis is the head of femur. Okay, so please remember, head of femur, and it is associated with which fracture? It is associated with fracture neck of femur or your posterior hip dislocation. So please remember, whenever there is a fracture neck of femur or there is a posterior hip dislocation, the blood supply to the head of the femur gets cut off, and the late complication of this fracture or this dislocation can be avian of this head of femur, which is the most common site of your avascular necrosis. This usually answers our question, but we'll also discuss some more sites where AVN is really very common. Apart from the head of femur, AVN is also common in the proximal scaphoid. Okay, so please remember, the blood supply to the proximal scaphoid would be cut off if there is a fracture of the waist of scaphoid. Agar waist of scaphoid, usually scaphoid is a boat shaped bone, right? So if scaphoid का waist का fracture हो जाता है, okay, for example I am just showing you, if there is fracture of the waist of scaphoid, the proximal part of the scaphoid would not receive any blood supply, leading to AVN of proximal scaphoid. Next one is your important one again, body of talus. AVN can also be seen at the body of talus. Talus is a tarsal bone, as we all know, and body of talus would suffer from AVN if there is fracture of the neck of talus. And the fracture of neck of talus is known as what? It is known as your aviatas fracture. This we have already discussed in the opponents. So it is known as your aviatas fracture, right? So body of talus would not receive the blood supply, predisposing it to avascular necrosis. What is the investigation of choice? I already told you. The investigation of choice for avascular necrosis is your bone scan. And as the activity, the metabolic activity is decreased in this area, usually you can see a cold spot on a bone scan. Cold spot can be seen. Okay, so important one. Now, if there is a bilateral idiopathic avascular necrosis, this avascular necrosis is not associated with any trauma, any other pathology. Okay, the cause is unknown. It is idiopathic and it is bilateral. In both the hips you can see bilateral idiopathic AVN. Okay, and it is usually seen in which age group? It is usually seen in children. Then this condition is known as Perthes disease. Question had come on this earlier. So please remember, bilateral idiopathic avascular necrosis, usually on the femoral head in children, is known as which disease? It is known as Perthes disease. And if there is a non-traumatic AVN, not associated with any fracture, any dislocation, if there is just a non-traumatic avascular necrosis, again common in the head of femur, usually seen in adults, then this would be known as which disease? Then this would be known as Chandler's disease. This would be known as Chandler's disease. At least remember the names over here. Okay, now going back to our question, guys. Okay, now I hope you can answer this easily. Patient was diagnosed as a case of AVN, okay, from a bone scan which shows a cold spot. Bone scan is the investigation of choice, as we all know. Okay, and they are asking which is the most common fracture associated with AVN. And the most common fracture associated with AVN is what? It is your option C, fracture neck of femur, which leads to AVN of femoral head. AVN of femoral head, right? Now moving further, guys, to our next question. Question number 24, which states a 12-year-old child was brought for delayed dentition and convexity in the chest. On examination, below given finding in images seen. All the following radiographic changes are seen in this condition except. So कौन सा radiographic change एक्सरे पे नहीं दिखेगा ये बताना है. Let's first of all make a provisional diagnosis. ये condition है क्या, तब जाके तो हम बता पाएंगे कि एक्सरे में क्या दिखता है क्या नहीं. So what is the provisional diagnosis in this condition? Okay, the child's age कितना है? 12-year-old child, presenting with delayed dentition and convexity in chest. Okay, and image क्या दिखा रही है हमें? Image is showing knocking of knees, and knocking of knees is known as what? Knocking of knees is known as genu valgum. So please remember, genu means knee, valgum means deviating from the center. Okay, so याद रखना, genu valgum दिखा रहा है हमें, knock knees. Okay, please remember this. And bowed knees is known as what? Bowed knees is known as genu varus. Okay, important one. So here we can see genu valgum. So usually genu valgum in a 12-year-old child associated with delayed dentition and convexity in chest. It is associated. This convexity in chest is known as pectus excavatum. Pectus excavatum. So this usual condition is seen in which disease? This is usually seen in a condition known as rickets. So our provisional diagnosis क्या है यहाँ पे? Rickets, right? So please remember. Now we need to answer which are all the radiographic changes which would be seen in rickets, okay, and which is not seen in rickets. So option A, delayed appearance of epiphysis. Option B, widening of physis. Option C, cupping and splaying of metaphysis. And option D, dense zone of provisional calcification. Now just answer in the chat box. In the meanwhile, we will be discussing rickets. So the important points that you need to know about rickets. We have already discussed about different types of diseases which are associated with cell, which are associated with protein. So one of the diseases were associated with defective or decreased mineralization of the bone. if there is defective or deficient mineralization of the bone, अगर minerals कम है body में and mineralization of the bone is not occurring properly, if calcium and phosphate are less in body, that would lead to decreased or deficient mineralization of the bone. Okay, and this usually mineralization of the bone occurs at the level of physis or your growth plate, right? So usually physis में mineralization होता है, that causes increase in the longitudinal length or longitudinal size or the length of the bone, right? So at physis, if there is defective mineralization of the bone, this condition is known as your rickets. Okay, if it occurs in children, it would be known as rickets. If it occurs in adults, it would be known as osteomalacia, that is softening of bone. The literal meaning of osteomalacia is softening of bone, again due to defective mineralization. These are the two diseases which are associated with decreased mineralization of bone, right? And which is the most common type of rickets usually seen in children? The most common type of rickets is usually nutritional rickets due to nutritional deficiencies. So what happens usually in rickets? There is vitamin D deficiency, and as there is vitamin D deficiency, that can lead to decreased absorption of calcium and phosphate. Vitamin D का main function क्या होता है? Increasing absorption of calcium and phosphate. If vitamin D is deficient, calcium and phosphate would in turn be deficient. That can lead to deficient mineralization of bone, right? So most common type of rickets, अगर question आता है, that would be your nutritional rickets, right? So what are the clinical features what can be seen in rickets? So please remember the important clinical feature in rickets that you need to remember. First of all, मैंने क्या बोला? Mineralization कम हो रहा है. That would lead to softening of bones, and softening of skull usually occurs in rickets. That is known as craniotapes. So what is craniotapes? It is softening of your skull bone seen in children. First thing. Second, what can happen? There would be dominance of this frontal bone. ये frontal bone बहुत ज़्यादा predominant हो जाएगा, and this condition is known as your frontal bossing. Okay, so please remember, why is this frontal bone predominant? Please remember, these are not being mineralized properly. The other skull bones are not being mineralized. That would lead to a very dominant frontal bone, that is known as frontal bossing. Okay, next one is caput quadratum. What do we mean by caput quadratum? It means squaring of your skull. Okay, so please remember, skull कैसा एकदम चौकोर जैसा हो जाएगा. It would become like a square, and the squaring of skull is known as caput quadratum. Next one, a very important finding is known as rachitic rosary. इसकी image all of us know now. It is known as your rachitic rosary. What do we mean by rachitic rosary? There is a beaded appearance of your ribs. Okay, these are your ribs, and there would be beaded appearance of your ribs. Important point. Rachitic rosary, a similar finding is also seen in scurvy. So how we need to differentiate between scurvy and rachitic rosary? In scurvy, which we see, it is known as a scorbutic rosary. Scurvy में क्या होगा? Scorbutic rosary, whereas in rickets what we can see rachitic rosary. What is the important difference? So please remember, in scurvy, the scorbutic rosary which is usually seen, it is tender. Okay, it is tender, that it is painful, it is sharp, and it is angulated. So three important findings क्या हो गए scurvy में? In scurvy, scorbutic rosary is usually tender, that it is painful, it is sharp and angulated. Whereas in cases of rickets, the rachitic rosary which is seen, it is non-tender, it is not painful, it is rounded. Okay, and it is not sharp. Okay, please remember this. That is your rachitic rosary. And just beneath the ribs, you can see a groove which is being formed. And this groove which is formed, it is known as what? It is known as your Harrison's groove or Harrison's sulcus. Okay, Harrison's groove या Harrison's sulcus बोला जाता है उसको. And the last finding that we have already seen in the image, we can see it is your knock knees. And knock knees को क्या बोला जाता है? genu valgum. So please remember, we can see genu valgum or knock knees in cases of rickets. Along with that, we can find two chest findings, either pectus carinatum, which is known as your pigeon chest. Okay, so please remember, pectus carinatum or pigeon chest, or we can see pectus excavatum. Okay, all of both these, either of these findings can be seen in the chest. Either concavity of the chest or convexity of the chest would be seen. Along with that, we can find delayed dentition. Mineralization सब जगह कम हो रहा है, ना कि सिर्फ bone में. Therefore, delayed dentition would also be seen, because teeth are also made up of what? Minerals, right? So therefore there would be delayed dentition. So now X-ray findings, which are very important in rickets. What are the important X-ray findings? What are the changes we can see in the epiphysis? What are the changes seen in epiphysis, and what are the changes seen in metaphysis? So please remember, in epiphysis usually there would be delayed appearance or absence of epiphysis. There would be either delayed appearance of epiphysis or absence of epiphysis. As we all know, epiphysis usually develops from the secondary ossification center. But in cases of rickets, as the mineralization of bone is delayed, therefore there would be delayed appearance of this epiphysis or absence of epiphysis in some condition. Okay. Whereas in scurvy, if we see, we can just see important changes in scurvy also. In scurvy, at the epiphysis, we can see a Wimberger sign. Okay. In scurvy, in epiphysis, we can see a Wimberger sign. We can see a round-shaped epiphysis. Ekdam round-shaped sclerotic epiphysis would be seen. That is known as a Wimberger sign in scurvy. Now, in physis, what are the changes seen in rickets? So, please remember, in physis, usually we can see widening in rickets. Okay? So, usually you check the wrist of the patient. Usually you check the wrist of the patient in rickets and you can see widening as compared to the other part of the bones. Okay, so widening of the physial plate can be seen in rickets. And what are the changes seen in metaphysis? So please remember, usually at metaphysis we can see cupping, splaying and fraying. I'll explain these three. So please remember, usually we can see cupping, splaying and fraying. सबसे पहले cupping क्या होता है? This type of metaphysis would be seen. There would be cupping of the metaphysis. Second, splaying क्या हो जाता है? So this type of splaying would be seen. Okay, widening of the metaphysis would be seen. That is known as your splaying. And lastly, fraying क्या होता है? That is irregular borders would be seen. That is your fraying. So please remember, cupping, splaying and fraying are the three findings which are seen at the metaphysis in cases of rickets. Important one. Okay. Then next one, serum calcium phosphate levels would be what? So please remember, as we have already discussed, in cases of osteoporosis, serum calcium levels are usually normal and SAP is also normal. But in cases of rickets, what happens? The serum calcium and phosphate levels are usually low, because that is the main cause, right? Decreased minerals in the body lead to rickets. So decreased calcium and phosphate levels in the body. Along with that, what happens with SAP? SAP is what? Serum alkaline phosphatase. So please remember, usually in cases of rickets, SAP is elevated. There will be increased levels of serum alkaline phosphatase. And lastly, serum vitamin D3, that is your calcitriol, which is the most active form of vitamin D, that would be decreased. Okay, that is the basic pathology, that is vitamin D dependent rickets mein hota hai, right? What is the treatment now? As there is deficiency of vitamin D, we need to supplement vitamin D. Therefore, we need to supplement vitamin D. And what is usual dose? It is your 60,000. So please remember, 60,000 is the usual dose of vitamin D3. So now, we'll just rule out one by one. Okay, option A, delayed appearance of epiphysis. It is seen usually in case of rickets. Option B, widening of physis, also seen in case of rickets. Option C, cupping, splaying of metaphysis. Yes, cupping, splaying and fraying of metaphysis was usually seen. Option D, dense zone of provisional calcification. Yes, this is your exception. Option D, dense zone of provisional calcification. Okay, please remember, also known as white line of Frankel. This dense zone of provisional calcification, also known as white line of Frankel. This is a radiographic finding seen in cases of scurvy. So please remember, you have a very close differential diagnosis known as scurvy along with rickets. So please remember, epiphysis में scurvy में क्या दिख रहा था? We can see the Wimberger sign, a round sclerotic epiphysis was seen, and along with that we can see a white line of Frankel at the metaphysis. Okay, यहाँ पे एक white line of Frankel दिखेगा, which is due to dense zone of provisional calcification. Okay, which is usually seen in scurvy. Along with that, we can see one more finding in scurvy, that is known as your Trummerfeld zone. What we can see? We can see a Trummerfeld zone. That is the radiolucent zone. Moving further to our next question, question number 25. A 58-year-old priest complains of pain and swelling in his knee. The most likely diagnosis is, and this question can be asked in anatomy also. So any answers, guys? Please tell me. What are the answers? Just tell me. Just tell me what are the answer. What is the answer over here? A 58-year-old priest complains of pain and swelling in his knee. The most likely diagnosis is what? The most likely diagnosis in this condition would be please tell me the most likely diagnosis in this condition. So let's discuss one by one, okay? So first of all, what do we mean by clergyman's knee? What do we mean by clergyman's knee? So please remember, clergyman's knee is nothing but your infrapatellar bursitis. As we all know, Patella has 3 bursa. Okay, one is above it, that is known as suprapatellar bursa. Then one is some just in front of it, that is known as prepatellar bursa, and one is beneath it, known as infrapatellar bursa. So this is your infrapatellar bursa. It is known as clergyman's knee. Second is housemaid's knee. What is housemaid's knee? Housemaid's knee is your prepatellar bursitis. Housemaid's knee is your prepatellar bursitis. So usually why it is known as housemaid's knee? So please remember, usually housemaid कैसे पोछा कैसे लगाती है? Just bending down on her knees. Okay. So due to repetitive trauma or repetitive contact of this knee or your prepatellar bursa with the floor, what happens? The inflammation is set in this prepatellar bursa, and this inflammation in the prepatellar bursa, known as prepatellar bursitis, is also known as housemaid's knee because it is common in this profession, in housemaids usually. What happens in clergyman's knee? What do we mean by clergyman? Clergyman means a priest usually. Okay, so what happens? Priest कैसे बैठता है प्रार्थना करने के लिए? They usually rest their knees. Okay, and the most common part of contact with the floor is what? It is your infrapatellar bursa. Infrapatellar bursa is the most common site of contact when the priest sits on his knees for praying. So okay, while the priest is praying, the contact is your infrapatellar bursa. So that can set an inflammation in your infrapatellar bursa, known as infrapatellar bursitis, and this condition is known as your clergyman's knee, which is infrapatellar bursitis, and option A is your answer. So please remember this. Okay. Then suprapatellar bursitis or pes anserine bursitis. What is pes anserine? Pes anserine is actually a tendon. Okay, so pes anserine is a tendon which is covered by this bursa. It is a tendon for your gracilis, semimembranosus and semitendinosus muscles. So please remember, pes anserine is a tendon for semitendinosus, semimembranosus and gracilis muscle, right? So next one, what are the important eponyms that we need to remember over here? Along with this clergyman's knee and housemaid's knee, we also need to remember 3 more important eponyms. Those are your tennis elbow, golfer's elbow and student's elbow. So what is actually tennis elbow? Tennis elbow is lateral epicondylitis. Tennis elbow is what? Tennis elbow is lateral epicondylitis. So inflammation of your lateral epicondyle is known as your tennis elbow. Okay. Next one, what is your golfer's elbow? Golfer's elbow is your medial epicondylitis. Golfer's elbow is your medial epicondylitis. Okay, please remember this. Due to repetitive trauma to this medial epicondyle. Okay, and last is your student's elbow. What do we mean by student's elbow? So please remember, student's elbow is nothing but your olecranon bursitis. Student's elbow is what? Your olecranon bursitis. Usually students rest their elbows on the bench, right? ऐसे बैठते हैं ना हम. So usually what happens, due to repetitive contact with the bench, this olecranon bursa can undergo inflammation known as olecranon bursitis, and this condition is known as your student's elbow. Okay, I hope this is very much clear to you. Now moving further, question number 26. A 12-year, if the treatment is not given in infancy, this condition can persist throughout the life. Okay, and therefore according to age, like age wise treatment hai hamare paas. So what is the preferred treatment modality in this age group, that is your 12 years of age group? So let's discuss some important points about your CTEV, that is your congenital talipes equinus varus. Okay, so please remember, there are few important deformities which can be seen in cases of congenital talipes equinus varus. Okay, first is your equinus. What do we mean by equinus? So equinus means your palmar flexion. Equinus is what? Equinus is your palmar flexion. Okay, ऐसा होता है पैर. Second is what? Second is your varus. Varus means inversion. Varus means what? Varus means inversion. Okay, and next one is cavus. What do we mean by cavus? Cavus means increased arc. Okay, this is your foot. Usually it has some concavity, but if this concavity is increased, okay, there is increased arc of foot, this is known as your cavus. So these are the important ones. Cavus, varus and equinus are the deformities seen usually in cases of CTEV. Okay, what are the different types of CTEV? CTEV can be either congenital, which is present from the birth itself, or it can be secondary or acquired. Okay, it can be the secondary or acquired due to different pathologies. It can be due to some fractures, it can be due to some diseases like rickets. Okay, so any of this can progress to CTEV. Remember this. So what are the findings that we can see on an X-ray? So please remember, on an X-ray usually we can find we need to see the talocalcaneal angle. We find the talocalcaneal angle. This talocalcaneal angle between the talus and the calcaneum bone, usually it should be more than 25 degrees. But in cases of congenital talipes equinus varus, this angle is less than 25 degrees. This angle is also known as Kite's angle. So please remember, this can be a one-liner. Kite's angle or talocalcaneal angle less than 25 degree is usually diagnostic of what? It is usually diagnostic of CTEV, that is congenital talipes equinus varus. Now the treatment of CTEV can be classified age-wise. Okay, if CTEV is to be treated within 1 year, that is during your infancy period, then the treatment of choice is what? Then the treatment of choice is your serial manipulation. Usually physiotherapists are given it is your serial manipulation and Ponseti casting. Okay, so we usually manipulate the joints and then we apply this POP cast in different positions. Okay, and this is known as your serial manipulation and Ponseti casting, right? And this is usually done in a sequence or in an order. If this order is not preferred, if this order is not followed properly, that can lead to a deformity of the foot known as rocker bottom feet. Rocker bottom feet is usually also seen in cases of Edwards syndrome, that is your trisomy 18. So please remember, in this cases also, in CTEV also, if during Ponseti casting the order is not followed, then that can lead to a deformity known as rocker bottom feet. And what is the order? So first of all we need to treat the cavus. Okay, first of all we need to treat the cavus, then we treat the adduction of the foot, then we treat the varus, and lastly we treat the equinus. So cave is the mnemonic. So please remember, this is the sequence: cavus, adduction, varus and equinus. This question had come earlier. Okay, what is the sequence of CTEV treatment? It is cave. Please remember, if the treatment is to be done in 1 to 5 years of age group, the child is presenting to you at between 1 to 5 years of age group, then the answer would be what? Then the answer would be posteromedial soft tissue release. Then the answer would be posteromedial soft tissue release. So what happens usually at the level of ankle? Okay, at the posteromedial side behind the tibia, there are these soft tissues which undergo spasm, and as these soft tissues they undergo spasm, that can also lead to congenital talipes equinus varus. So between 1 to 5 years of age group we need to cut these tissues. Okay, and this procedure is known as posteromedial soft tissue release. Between 5 to 10 years of age group, the preferred treatment modality would be Dillwyn-Evans osteotomy. What is the procedure's name? It is your Dillwyn-Evans osteotomy. So what we do in this condition, we actually fuse the foot on the lateral side. Okay, we actually cause fusion of your calcaneocuboid angle. Usually cause fusion of your calcaneocuboid angle. So उसके वजह से क्या हो जाता है? The lateral part of the foot does not grow, the medial part keeps on growing, and this can straighten the foot. Okay, this can straighten the foot. So what happens usually in Dillwyn-Evans procedure or Dillwyn-Evans osteotomy, there is a fusion of calcaneocuboid angle. Important. And beyond 10 years, if the child presents to us with CTEV, then the preferred treatment modality would be triple arthrodesis. The preferred treatment modality is what? It is triple arthrodesis. Important one. Okay, in triple arthrodesis what we usually do? We usually open the foot, we correct the deformity, and then we fuse some joints, because CTEV is recurrent. If you could not fuse the joint, then the condition would reverse again. Therefore we need to fuse some important joints. Those are your subtalar joint, calcaneocuboid joint, okay, calcaneocuboid joint, and talonavicular joint. So please remember, in cases of triple arthrodesis, after 10 years of age, when we need to treat CTEV, we usually perform triple arthrodesis. In that we open the foot, we correct the deformity, and then we fuse the subtalar, calcaneocuboid and talonavicular joint. And after any of these procedures, even after Ponseti casting or posteromedial soft tissue release or Dillwyn-Evans osteotomy or triple arthrodesis, after any of these procedure, we need to maintain the foot in that posture itself. So maintenance of this is done either with your CTEV shoes, or a splint that we have already discussed, and which was a question in your June 2021 session, that was your Dennis Brown splint. Okay, so please remember, maintenance of CTEV treatment is usually done with CTEV shoes or your Dennis Brown splint. Yes, usually triple arthrodesis can be performed after skeletal maturity, but like most of the books prefer it after 10 years of age. Okay, because other procedures like Dillwyn-Evans osteotomy or other conditions have not given better results at 10 to 15 years of age. Therefore triple arthrodesis is usually preferred after 10 years of age. Then this is your condition, that is congenital talipes equinus varus, right? CTEV. Over here you can see adduction of the foot. Under RI foot, right? You can see increased arc of the foot. That is cavus. Okay, so that is your cavus. बीच में आ रहा है, that is your adduction, right? There is inversion of foot known as varus, okay? And lastly, here we can see equinus, that is your palmar flexion can be seen, right? Next, these are your club foot splint or shoes. So please remember, CTEV is also known as club foot. So this is the splint which is used for maintenance, or these are the shoes. And Dennis Brown splint we have already discussed earlier, right? So now this is one more condition. Just see over here. This is the developmental dysplasia of hip. Okay, here the bones are not properly formed; they are dysplastic. Okay, the formation of bone is defective. So developmental dysplasia of hip (DDH) in this splint is usually preferred, known as von Rosen splint, or this is known as your Pollock's harness. Please remember the important images. These are the only probable questions which can come in exam. So von Rosen splint or Pollock's harness are the splints used in cases of DDH, that is developmental dysplasia of hip. This question had come earlier already, Pollock's harness. Okay? And Barlow's and Alternatives test, both of these tests are also performed in cases of DDH. Moving back to our question, so this is a 12-year-old child brought to the OPD with CTEV, and treatment was not taken earlier. Which is the preferred treatment modality now? So the preferred treatment modality in this condition would be option D, that is triple arthrodesis, because the child is more than 10 years of age, right? Moving further to our question number 27, here a patient presents with pain around the knee joint. Here the patient presents with pain around the knee joint and gives a history of sudden twisting injury on a flexed knee. You suspect an ACL injury, that is your anterior cruciate ligament injury. The first step to be done in this case. उन्होंने क्या पूछा है, सबसे पहले क्या करोगे? The first step, and the options are MRI, option B arthroscopic ACL reconstruction, option C conservative management, and option D anterior drawer test. So what is the preferred treatment in this case? The first step that we can do in this case is, so please remember, we'll discuss important points about your anterior cruciate ligament injuries. So your ACL injuries are very important. Why? Because they are the most common knee ligament injuries. So please remember, the most common knee ligament injury, the question if asked, what would be your answer? The answer would be anterior cruciate ligament, ACL injuries. What is the mechanism of injury? So please remember, ACL injuries are due to sudden twisting force on a partially flexed knee. They are due to a sudden twisting force, okay? So a sudden twisting force on partially flexed knee. So that is the mechanism of injury usually in cases of ACL injuries. Next, what is the clinical test that we usually perform? The clinical test usually performed are your anterior drawer test. Okay, so anterior drawer test में क्या करते हैं? We try to pull the knee towards us. Okay, anteriorly we try to pull the knee. And अगर anterior cruciate ligament नहीं होगी resistance provide करने के लिए, so the tibia would come in front. Okay, without resistance the tibia would move anteriorly. Okay, that is known as your anterior drawer test. And anterior drawer test is usually done in 90-degree flexion. So knee is in 90-degree flexion. So please remember this. This is the anterior drawer test, which is the clinical test of choice in cases of ACL injury. And the second one is your Lashman's test. Lashman's test is also performed for ACL injuries, and Lashman's test is done with knee in 5 to 20-degree flexion. With knee in 5 to 20-degree flexion. Next, for PCL, that is your posterior cruciate ligament. For PCL injuries also we have a clinical test known as posterior drawer test. Here we try to push the tibia backwards, and as the PCL is injured, the tibia would be pushed backwards without any resistance. So this is known as your posterior drawer test. Then what is the O-Donoghue triad? Question has been asked and can be asked on this again. So what is the O-Donoghue triad? So please remember, O-Donoghue triad is an injury to your anterior cruciate ligament plus your medial collateral ligament plus your medial meniscus. So please remember, this is a triad of soft tissue injuries in the knee, and O-Donoghue triad is injury to the anterior cruciate ligament ACL, medial collateral ligament MCL, and the medial meniscus. What is the investigation of choice of these ligament injuries in the knee? The investigation of choice for these ligament injuries is your MRI. Usually for any neural tissue, for any ligaments, okay, the preferred investigation is your MRI. So please remember, the investigation of choice for any of the soft tissue or your ligament injuries would be MRI. What is the treatment in cases of ACL injuries? The treatment would be arthroscopic ACL reconstruction. We put inside a scope, that is a camera जाता है joint में, okay, and that along with the help of that camera we repair this ACL, your anterior cruciate ligament. So arthroscopic ACL reconstruction, and this arthroscopic ACL reconstruction. ACL is injured, it is broken down now, so it can be repaired with the help of some tendons. And which are the tendons which can be used? So please remember, it is your gracilis plus semitendinosus tendon which can be used. Please remember, gracilis plus semitendinosus tendon is usually preferred in arthroscopic ACL reconstruction. Okay, going back to our question now. A patient presents with pain around the knee joint and gives history of sudden twisting injury. You suspect ACL injury. First step क्या करोगे? Are we going to directly go for an MRI? Okay, MRI बहुत महंगा होता है. Okay, it is not usually a preferred choice in the first go itself. So are we directly going for an MRI, or we are performing arthroscopic ACL reconstruction directly without just making a proper diagnosis? We are just suspecting ACL injury. We are not diagnosed it. So this is also not the preferred choice. Next, conservative management. Usually ligament injuries cannot be conservatively managed. Okay, they need to be repaired, and mostly ACL injuries needs to be repaired at any cost. So again, this is the wrong choice. So the first step that you will do is usually you will check or examine the patient clinically, right? And for clinical test, you have this anterior drawer test. So the first step to be done in this case is your anterior drawer test, right? Very good, guys. Moving further to our next question. Before that, just see, this is your knee ligament anatomy. This is your anterior cruciate ligament, which comes from the posterior aspect and gets inserted on the medial condyle of your tibia. This is your posterior cruciate ligament, okay, which goes posteriorly from the medial part of your femur to your lateral condyle of the tibia. These are your medial collateral ligaments, okay, medial collateral and lateral collateral ligament, and these are your menisci. Menisci actually just, what we can say, they just prevent friction between these joints, okay, medial meniscus and lateral meniscus. Next are your ankle ligaments. Ankle ligaments are important. Please remember, okay, ankle ligaments are the most common ligament injury in the body. मैंने क्या बोला था? Anterior cruciate ligament is the most common ligament injury in the knee. But overall in the body, which are the most common ligament injuries? Those are your ankle ligament injury. Okay, so please remember ankle ligament injury. Ligament injuries are usually known as sprain. Okay, ligament injuries are usually known as sprain, and muscle injuries are usually known as strain. याद रखना, ligament are sprain, muscle are strain. Important one. Moving further, this is your Lachman's test, usually done in 5 to 20 degree flexion of the knee. This is your Lachman's test done for ACL injury. This is your anterior drawer test, right? The tibia comes forward. This is your anterior drawer test done in 90 degree flexion of the knee, okay, and this is your posterior drawer test for PCL injury. This is your bucket handle tear. Okay, usually if the meniscus is injured, the most common pattern of meniscal injury is this bucket handle tear. Okay, important. Next, question number 28. A patient was diagnosed as a case of medial meniscal injury. All the below given statements are true except, so we need to find the incorrect statement or the false statement. So हमें क्या ढूंढना है? We need to find the false statement. So just before moving on to this, let's discuss few points about your menisci. Again, I have told you guys, soft tissues are important. Ligaments and menisci, on these questions have been asked repeatedly. So just don't forget about these, okay? So menisci are what? So please remember, menisci, like we have medial meniscus and lateral meniscus in the knee joint, which prevents friction. So इनका main काम क्या होता है? These acts as shock absorbers. These usually acts as shock absorbers in the knee. Okay, these usually acts as shock absorbers, and second function is they are responsible for equal weight distribution. They are responsible for equal weight distribution. Okay. Now, which is we have two menisci, that is medial as well as lateral. Which is the most common meniscal injury? Please remember, medial meniscal injury is the most common meniscal injury. Most common meniscal injury is your medial meniscal injury. Also remember, it is the most common soft tissue injury in the knee. Okay, so important points क्या क्या याद रखने हैं अभी याद रख लो. Most common soft tissue injury in knee question आता है, so answer would be medial meniscal injury. अगर क्वेश्चन आता है most common ligament injury in knee, then the answer would be anterior cruciate ligament. And most common ligament injury inside the body, then the answer would be your ankle ligament. Okay, please remember the spring ligament usually it is called as, right? Next one, most common tear. So please remember, the most common tear in medial meniscus is usually at the posterior horn. Most common tear in medial meniscus is at the posterior horn of this medial meniscus. Most common type we have already seen in the last image. The most common type is your bucket handle tear. Most common type of your medial meniscus injury is your bucket handle tear, कुछ इस तरह से tear होता है, right? Important. Next, what is the most common symptom or the most common clinical feature in medial meniscus injury? So please remember, there would be locking of the knee joint along with pain. There would be locking of the knee joint along with pain. This is the usual clinical feature with which the patient presents to you. There would be locking of the knee joint along with pain. Now, what are the clinical tests? Okay, what are the preferred clinical tests in this condition? The preferred clinical test in this condition would be Mac-Murray's test and Apley's grinding test. Okay, the two preferred tests are your Mac-Murray's test and the Apley's grinding test. Okay, just remember the name, these are important. Okay, so Mac-Murray's test or Apley's grinding test are usually performed for your medial meniscus injuries, out of which Mac-Murray's test, double MRI isme, so it is the most common clinical test preferred in cases of medial meniscus injury. Most commonly performed test in cases of medial meniscus injury is what? Mac-Murray's test. It is your Mac-Murray's test. But which is the best test? It is neither Mac-Murray's test, it is nor Apley's grinding test. So the best test for your medial meniscus injury is what? So please remember, the best test for your medial meniscus injury is your joint line tenderness. You just check tenderness at the joint line. Okay, so joint line tenderness is the best test performed in cases of medial meniscus injuries. What is the investigation of choice? Again, I have told you, for any of the soft tissues, the investigation of choice would be MRI. But what is the gold standard test? So please remember, gold standard test would be arthroscopy. Gold standard क्या होगा? Arthroscopy. When we are actually putting the camera inside the joint and we can actually visualize what is happening inside the joint. So the gold standard test is arthroscopy. So guys, I'll tell you the difference between gold standard and investigation of choice. So gold standard का मतलब होता है, it is the best test which is available right now, but it is not always practically possible to perform this test. Okay, either there are financial restrictions or there are many complications because of this test. But theoretically अगर बात करें, gold standard tests are the best tests possible. But investigation of choice is such a test which can be easily performed also without any financial restrictions or without any complications, right? So please remember, investigation of choice is practically possible, whereas gold standard at times it is not practically possible. Okay, this is the difference. And what is the treatment in this condition in medial meniscus injury? So please remember, the treatment in cases of medial meniscus injury would be medial meniscectomy. Okay, meniscectomy. हम menis का निकाल के फेंक देंगे. Okay, so arthroscopic medial meniscectomy is the treatment of choice. Now let's go back to our question. A patient was diagnosed as a case of medial meniscus injury. All the statements are true except, so which is the false statement? Let's see. Option A, it is the most common soft tissue injury in the knee. Yes, it is. Option B, Mac-Murray's test is the most common clinical test performed. Yes, most common is Mac-Murray's test. Best test is joint line tenderness. Option C, MRI is the gold standard investigation. No, right? MRI is the investigation of choice. It is not the gold standard investigation. It is the arthroscopy which is the gold standard investigation. So option C is the wrong statement over here. So that is a correct answer. And option D, bucket handle tear is the most common type of injury. Yes, it is. Now moving to our question number 29. Here they are saying a 60-year-old female was diagnosed with Colle's fracture after a fall on an outstretched hand and was treated with closed reduction and below elbow POP cast. Which is the most likely complication with which she can present to you? And options are Fork Deformity, finger stiffness, carpal tunnel syndrome, Sudeck's osteodystrophy. Your answers, guys. So let's discuss some important points about Colle's fracture in the meanwhile till you answer the question. So what is Colle's fracture? Important point. सबसे important point क्या होगा? Colle's fracture is an extra-articular fracture. It does not involve your joint. So please remember, Colle's fracture is an extra-articular fracture not involving the joint. It is the fracture of the distal end of the radius. Okay, it is the fracture of your distal end of the radius near to your wrist joint, right? It is more commonly seen in which age group? It is more commonly seen in elderly, osteoporotic, menopausal females. Usually what happens after menopause, there is decreased action of estrogen which leads to osteoporosis. So usually in cases of elderly, osteoporotic, menopausal females, we try to encounter Colle's fracture, right? What is the mechanism of injury? Mechanism of injury of Colle's fracture is push. What do we mean by push? Fall on an outstretched hand. जब इंसान ऐसे गिरता है, we try to support with our extended hands. That is our push. So fall on an outstretched hands in an elderly osteoporotic menopausal female can commonly lead to Colle's fracture. What is the displacement usually seen? In cases of Colle's fracture, we can see the fractured fragment which is there. So for example, this is your radius, okay, and this has been fractured. So the fractured fragment which is there, this is usually displaced dorsally or laterally. There is a dorsal or lateral displacement seen. Okay, what is the treatment? So please remember, usually Colle's fracture dislocation is usually treated with what? It is usually treated with closed reduction. Okay, it is usually treated with closed reduction by applying traction and counter traction, and we manipulate it. Okay, we manipulate this fractured fragment. So there is closed reduction, and then we apply a below elbow POP cast. Below elbow plaster of Paris cast is applied after this closed reduction. And this below elbow POP cast is usually applied in what position? This question has been asked. So the below elbow POP cast usually given in Colle's fracture is applied in which position? It is usually applied in your hand shaking position. It is usually applied in your hand shaking position. Important. Hand shaking position means what? The wrist would be in palmar flexion. Okay, the wrist would be in palmar flexion. Okay, important. And there would be ulnar deviation. So wrist is in palmar flexion and ulnar deviation. So this is palmar flexion and this is medial deviation, that is your ulnar deviation. So this is your hand shaking position. Which are the complications seen along with Colle's fracture? So which is the most common complication? So the most common complication seen along with Colle's fracture, please remember, it is your finger stiffness. So please remember, joint stiffness or finger stiffness is the most common complication seen with Colle's fracture. Okay, this we tend to miss out. Most common complication after Colle's fracture is your finger stiffness. Important. Then Colle's fracture, if it is malunited, agar malunion ho jata hai, galat jud jata hai fracture, then this malunion can lead to a deformity known as dinner fork deformity. कौन सी deformity दिखेगी? We can see dinner fork deformity as a complication of malunion of Colle's fracture. And it is the second most common complication. याद रखना, it is the second most common complication, not the most common one. Then it can also lead to carpal tunnel syndrome. Okay, it can also lead to carpal tunnel syndrome due to compression of your median nerve, and also it can lead to Sudeck's dystrophy. Okay, Sudeck's osteodystrophy, which is a reflex sympathetic osteodystrophy. Right? Now, what is a reverse Colle's fracture then? So please remember, reverse Colle's fracture is also known as your Smith's fracture. Reverse Colle's fracture is also known as your Smith's fracture. Again, it is also a fracture of your distal end of radius. ये भी fracture किसका है? Of distal end of radius. This fracture is also extra-articular. So what is the difference? In that we have seen in Colle's fracture, the displacement was dorsal or lateral. But in cases of Smith fracture, the displacement is ventral, anterior displacement दिखेगी. Okay, the fractured fragment would be displaced anteriorly. Right? And what is the complication? So please remember, if the Smith's fracture or the reverse Colle's fracture is malunited, due to this malunion, it can lead to a deformity known as garden spade deformity. कौन सी deformity दिखेगी इसमें? Garden spade deformity would be seen. So in Colle's we can see dinner fork deformity, and in Smith's we can see garden spade deformity. Important two deformities that you need to remember. So moving back to our question. So now, a 60-year-old female with Colle's fracture, fall on an outstretched hand, closed reduction and below elbow POP cast. Which is the most likely complication now? The answer would be option B. Finger stiffness is the most common complication, followed by dinner fork deformity. Moving further. So just see guys, this is your Colle's fracture. In this image you can see. And ये जो protrusion दिख रहा है, this is because of the fractured fragment which is displaced dorsally. Okay, the fractured fragment which has been displaced dorsally. Due to this you can see over here, this protrusion on the wrist. Okay, so it is a fracture of distal end of the radius with dorsal displacement, and it can lead to dinner fork deformity. This is how a dinner fork deformity would look like if the fracture is not properly manipulated during reduction. Okay, this is the radius, and this is after reduction. Okay, this is post reduction, how a fracture would look like. Then this is what? This is your Smith's fracture, and this is your garden spade deformity. ये कौन सी deformity है? Garden spade deformity. Okay, this is also a fracture of distal end of radius, but now with ventral displacement of the fracture fragment. And here we can see the garden spade deformity. Here also you can see this is the post reduction and this is the pre-reduction X-ray. So what are these important two fracture dislocations? So please remember, these are fracture dislocations seen in the forearm, and these are most important from your exam point of view. So please remember how we need to remember this. So we remember it by this mnemonic known as Muger. That is in Monteggia there is ulnar fracture and in Galeazzi there is radial fracture. ठीक है, ऐसे याद रखते हैं हम usually. Okay, so this is your Monteggia fracture dislocation in which the proximal 1/3 of the ulna gets fractured. The proximal 1/3 of the ulna gets fractured and the proximal radioulnar joint or the superior radioulnar joint is dislocated. There is anterior dislocation of the radial head. Whereas in cases of Galeazzi fracture dislocation, what happens? Okay, Galeazzi में radial fracture होता है. Therefore, there is fracture of the distal 1/3 of the radius. Distal 1/3 of the radius shaft gets fractured along with inferior or distal radioulnar joint dislocation. Okay, so there is posterior dislocation of the ulnar head. Right, important one. Moving further to our next question, question number 30. A 35-year-old male presented with shoulder dislocation. The X-ray is given below. Over here we can see the X-ray. The patient gives history of dislocation of same shoulder 4 times in the last year. So last year the patient has experienced the same site में dislocation for almost 4 times now. The preferred treatment modality in this condition is. So here we can see what? Okay, either it is usually shoulder dislocations are either inferior, anterior or posterior dislocation. Superior it cannot go because of this acromion process. Right, here we can see the humeral head is coming anteriorly. So this is your anterior shoulder dislocation. Usually if there is a posterior shoulder dislocation, that can lead to a light bulb sign. Okay, in cases of posterior shoulder dislocation, that leads to a light bulb sign. Okay, so now let's discuss few points about recurrent dislocation. So this case where there is same site dislocation for more than 4 times now, this is a case of recurrent dislocation. This is a case of recurrent dislocation. So what how do we define recurrent dislocation? There is 3 or more dislocations of the same site or the same joint. If there is 3 or more times dislocation of the same joint, this is classified as your recurrent dislocation. And the most common shoulder joint which undergoes recurrent dislocation is your anterior dislocation. The most common type of dislocation in shoulder is anterior, and the most common type of dislocation which undergoes recurrent dislocation is also anterior dislocation. Okay, so most common overall is anterior shoulder dislocation. Now this recurrent dislocation can be due to some lesions. Either it can be a Bankard's lesion or it can be a Hill-Sachs lesion. It is Hill-Sachs lesion. Okay, so what do we mean by a Bankard's lesion? So Bankard's lesion mein there is a antero-inferior glenoid labrum tear. Okay, so usually what happens in the shoulder joint, there is a glenoid labrum. Okay, and this glenoid labrum prevents the shoulder joint to be dislocated anteriorly. But dislocation usually due to a Hill-Sachs lesion, then your answer would have been Bristol-Lataget procedure, right? Moving further, and in Bristol-Lataget procedure actually we perform coracoid osteotomy. So Bristol-Lataget procedure and coracoid osteotomy is one and the same thing. Important one. Then moving further to our next one, guys. So these are some important shoulder diagnosis is what? Just sorry guys for the interruption in your internet connection. I'm just not sure why it is loading again and again. I hope nothing is being cut out. You can hear me loud and clear. I'll just try to rectify this once again. Just a minute. I hope this helps somewhat. Yeah, now let's begin with our session again. Okay, so this condition, the most likely diagnosis in this condition is what? It is your option D, nursemaid's elbow. What do we mean by nursemaid's elbow? Nursemaid's elbow is also known as your pulled elbow. Nursemaid's elbow is also known as your pulled elbow. So what happens usually in pulled elbow? So please remember the radial head, okay, the radial head which usually articulates with the radial fossa of the ulna. अल्ना में एक रेडियल फोसा होता है जहाँ रेडियल हेड आर्टिकुलेट करता है, which forms the superior radioulnar joint. So what happens when we move the child around like this by holding the in this condition is what? So please remember treatment usually